started. I'll start with a land acknowledgement. The University of Calgary, located in the heart of southern Alberta, both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda. And the City of Calgary is also home to the Métis Nations of Alberta Districts 5 and 6. So we are happy to have Dr. Satish Raj for our grand finale. And I think most of you will know him, but Dr. Raj is a professor of cardiac sciences and the section chief of the cardiac arrhythmia group. He also serves, of course, as the director of education for the Libin Institute and the clinical lead for the Women's Cardiovascular Health Initiative in the Cummings School of Medicine. After spending 12 years working at the Vanderbilt Autonomic Dysfunction Center in Nashville, Tennessee, he moved back to Calgary in 2014 and founded the Calgary Autonomic Investigation and Management Clinic. He runs an active research program in human autonomic physiology, and his primary research interests relate to understanding and better treating POTS, vasovagal syncope, and orthostatic hypotension. So join me in welcoming Dr. Raj.
Thank you, Jennifer. Before I get started with the talk itself, I don't know how many of you know that last night at the Cardiac Sciences and Sword of Libin Awards, Jennifer Thompson was recognized for winning the Todd Anderson Award for Early Career Investigator for this last year. So quick round of applause for Jennifer. And what people don't realize is that it actually comes with more research cash than any of the other awards. So it's actually the best award to get from that point of view. So I was asked to talk about POTS, and instead of, there's obviously a lot of things on any topic to talk about. And if I was giving this talk to a primarily clinical audience, I'd want to make sure that I covered treatment approaches and the such. But there's actually a fair bit of data sort of that we and others have gathered on the role of women, both in terms of being affected by POTS as well as going through the journey from diagnosis to care. And I will say most of the work that I'm going to be presenting actually was led by Kate Bourne, who finished her PhD in our lab last year and is currently a medical student. I actually asked her if she wanted to give this talk since she did a lot of the work. And unfortunately, maybe fortunately for her, unfortunately for us, she is on a clinical rotation in the cardiac intensive care unit, and didn't think it would look good if she sort of disappeared halfway through the day. So when you see the data, think Kate. So my disclosures are listed here. Nothing really that's affecting the talk in great depth, actually in any depth. What I'll say about the consulting honoraria that's listed here is first, unfortunately, no one makes enough real money to make me rich yet. But the reason I put this up is that if I gave this talk 10 years ago, that would be totally blank, right? One of the things that's changed, perhaps as a result of COVID and the general mainstream awareness of POTS, is that it's actually generated some interest from industry, pharma industry in particular, in trying to find novel molecule solutions for this. And by that, I mean, we've done work for years on drug trials, and the drugs we use typically are 60 or 70 years old and are very generic and mechanistically seem like they could be helpful, and we look at them. But up until recently, there's no one that's actually looking at novel pathways and novel molecules. And so it's actually quite exciting that there's interest. Now, nothing is close to the clinic. These are all very early stage trials, but if we watch this space over another 10 years, hopefully some will develop into real novel therapies. So we'll start by what is it, right? We sort of talk about POTS. POTS stands for Postural Orthostatic Tachycardia Syndrome. I guess the first thing to understand is it's a form of orthostatic intolerance, right? These patients feel unwell when they're upright. It is a positional disorder. The other part of this is it's chronic. And the reason I make that point is I'll go through the criteria later. But actually, let me just throw it. It's May right now. So we've been through sort of most of the winter cold and flu season. How many people had a reasonably bad cold or flu, over the last 6 months? Right, so most of us, right? I mean, when you live in Canada, I figure I'm good for 1 or 2 good viruses every winter, right? And that certainly existed pre-COVID, and I think we're back to that. If you actually feel particularly scientific, the next time you feel like crap with a bad cold or a flu, when I go through the criteria, make note of them and actually measure your heart rates from lying and standing and pay note of your symptoms. I think you'll find that many of you would actually meet criteria for POTS acutely when you're feeling unwell. The difference between that and the patients that we label POTS is that in most of us, that goes away in a few days. And then you're left with a lingering cough for 2 weeks or whatever. But the acute unwellness goes away fairly quickly. While in these patients, it doesn't. It becomes a chronic disorder. And we define chronic as lasting at least 3 months. Used to be 6 months. It turns out that probably doesn't make much difference. But the point is the symptoms themselves are common. It's the presentation and the lack of resolution that's the problem. There have been studies looking at quality of life using very generic quality of life tools like the SF-36, and the quality of life has been comparable to patients with congestive heart failure, who we know through the Live and Heart Institute have a high mortality and a poor quality of life, and patients with chronic obstructive pulmonary disease, right? So typically affecting older, sicker patients. These aren't older patients anyway, but the level of disability, if you will, from quality of life is that bad. And it's estimated to affect 1 to 3 million people in the US. It's precise numbers are hard. The number we throw around is about 1% of the population. These are all back of the napkin estimates, right? Until recently, and actually officially outside the US, there's still no ICD code for POTS. That's going to be changing in the future. But for our colleagues in the O'Brien Institute, where they do a lot of health services research based on coding, there's not a code for it. You can't measure it in a more precise way. So these are estimates based on clinics. And I guess of most relevance to the group here, the overwhelming majority of patients are female. We used to say sort of over 80%, but as you'll see in a lot of our more recent data collections, it's actually over 90% of the female patients are female. And one of the challenges in terms of trying to really get at the root and treatment of POTS is that it's probably not a single disease. It's a disorder that has different mechanistic pathophysiologies that end up with a common phenotype, which we'll discuss, but with tachycardia, as you can imagine from the name, being a big part of it. So when someone stands up, lots of things happen. One of the key things is that fluid shifts from our chest, where our heart is, to below our chest, where our heart isn't. And the amount varies. It's probably between half a liter and a liter. It varies based on lots of things, one of them being size. But the truth is this happened to all of us. At a very young age, we learn to be vertical, around 1 plus or minus a few months, depending on how precocious you are, right? And we never think about it. And that's because the body adapts to this change imperceptibly quickly, usually, and often no symptoms are felt, right? But the point is adaptations have to be made to deal with this fluid shift. So the problem in POTS is that it doesn't always go so well. And the patients, when they're upright, don't respond appropriately, and they can have a myriad of symptoms, including a sense of palpitation from a rapid heartbeat, lightheadedness, fatigue, issues with blood pooling, as well as skin changes that may or may not be related to that. And there are hemodynamic targets sort of based on that, right? Where the underlying problem may be they're fundamentally not churning enough blood, and it's a state of inadequate supply. Okay, so that's fine. That's what the problem is, but what is it? How do we define it? And the criteria that are basically used by most people are listed here. And they've undergone minor refinements, but they've basically been the same since first described just over 30 years ago. And so what was described was a group of patients, predominantly women, it may have been exclusively women in the first series, who had an excessive increase in their heart rate on a tilt table test. We now use standing as somewhat of a surrogate. It's not exactly the same, but as a day-to-day surrogate. But a heart rate increase that was excessive, and they defined excessive as 30 beats or more. So it's a little inaccurate. We said greater than 30, 30 would count. Now, one of the problems with using orthostatic tachycardia is that it is physiologic, right? So the heart rate going up isn't abnormal. We're saying it's excessive, but it turns out the amount the heart rate goes up varies with age. And in young people, it goes up a lot quite normally. And one of the things that these guys did, the original criteria came out of Mayo Clinic, and they actually went to, the schools and pulled in, volunteers to study them. And a lot of teenagers had an increase that was greater than 30 beats per minute that were perfectly fine and healthy. And so they looked at this and they redefined the criteria in children. So what I mean by that is ages 12 to 19, requiring 40 beats or more. Okay, now that's not perfect because even among the adults, the normal orthostatic tachycardia decreases with age. And so an increase of 30 beats per minute in a 20-year-old is less impressive than an increase of 30 beats per minute in a 50-year-old, right? Because physiologically, that usually would be expected to go down. But that, in clinical medicine, you have to make a trade-off between precision and what you can actually remember in the clinic and use. And so we've sort of set on a fixed number. And importantly, this has to occur in the absence of orthostatic hypotension, not because it's unimportant if you have orthostatic hypotension, but because that's been long recognized as its own disorder and requiring treatment. So the whole point is this was sort of a different group that had been ignored up to that point. What I've described so far is POT, not the marijuana kind, the other kind, right? Postural orthostatic tachycardia. I've described physiology. And physiology is necessary for diagnosis of POTS, but it's not adequate. What you need for a diagnosis of POTS is the syndrome. And the syndrome means a bunch of symptoms that these patients have that look like these other patients, and it's a starting point for care. And so specifically, the symptoms can vary, but the symptoms have to be dominant symptoms that are worse when they're upright and better when they're lying down. Not all the symptoms, but dominant symptoms. If people come to you and they have all these symptoms and position doesn't matter, it's not POTS, right? It's a postural symptomatic disorder. As I mentioned, it has to be chronic. And then the other caveat is, there are drugs, there are other physiologic conditions that we know predispose to orthostatic tachycardia. The goal is not to put someone on a stimulant, get their heart rate up and say, you have POTS, right? This has to be in the absence of reversible things that could be causing it. Now, a few years ago, we put together a position statement on behalf of the Canadian Cardiovascular Society. And when we were doing it, we wanted to highlight that POTS required both excessive, lots of symptoms. I don't know if this pointer is working or not. Okay, lots of symptoms on the x-axis as well as lots of tachycardia on the y-axis. You need a both for diagnosis of POTS, right? But we recognize that there was often sort of misdiagnosis and confusion over this. And so we actually created a nomenclature for other disorders that weren't POTS, that were probably something that needs to be better defined. And so there are a lot of patients, for example, that are quite symptomatic with orthostatic intolerance. They'll feel worse when they're upright, but they don't have excessive orthostatic tachycardia or meet that criteria. And so we defined a term called postural symptoms without tachycardia, or PSWT. Now, I will say that people hate the term because, let's face it, it doesn't roll off the tongue like POTS, right? So if any of you are good at acronyms and want to come up with a better term for this, wide open to it, because I think that's limited adoption of this, but it doesn't alter the main point that, this is an issue. It gets even more complicated than that, in that, we can talk about POTS as a, primarily hemodynamic or cardiovascular issue, but the truth is there are many patients that really have other clinical issues that sometimes dominate their presentation, that sometimes cause a lot of their symptoms and reduction in quality of life. And we thought it was important to understand this, because if we fix the cardiovascular issues and their main problem is something related to their gut, or their main problem is a severe allergic phenotype, we may help somewhat, but we're not going to make a big distinction or improvement in their quality of life. And so we came up with this plus terminology. So for both POTS and PSWT, there's sort of the purer version, and then there's the penumbra of POTS plus, POTS with other things. Just recognizing the response, if you look at quality of life in response to treatment, it may be different. And we just list here, it's not an exclusive list or an exhaustive list, but disorders that are commonly seen and comorbidities that are commonly seen in patients that sometimes have an overriding effect on their presentation. We get to a more basic discussion of what the common symptoms we see in our patients or in our clinic. They're listed here. And as a cardiologist, I've broken them down into things that I can blame on the heart and things that I have more trouble directly blaming on the heart, right? On the left, the things you'd expect, rapid palpitation from rapid heartbeats, chest discomfort, shortness of breath, lightheadedness. Easily, I could blame the heart for all of these. But there are symptoms that are almost as common. Almost everyone complains of brain fog or subjective cognitive impairment, mental clouding. Headaches, well over 90% have headaches. Nausea, it turns out nausea is not a symptom, it's actually two symptoms, right? There's a nausea that gets worse when you eat, but there's also a postural nausea that sometimes gets worse when you stand up. And those two require different treatments. And a tremulousness or inner shakiness. And all the symptoms I've talked about in black are worse when they're upright, or can be worse when they're upright. But again, not all the symptoms in POTS occur upright. So patients typically have an exercise intolerance as part of this. Patients typically are chronically fatigued. Almost everyone I see is chronically fatigued. Not everyone meets diagnostic criteria for ME/CFS. So not everyone has chronic fatigue syndrome, but everyone's chronically fatigued. And a lot of patients have trouble with their sleep. And we certainly don't ask them to sleep upright, right? But so it's part of a broader disorder. But the point is not just a cardiovascular disorder, but a multi-system disorder with a very strong cardiovascular component. So this is a tilt test of a healthy control participant and a POTS patient. This was done when I was at Vanderbilt. So healthy control means grad student, if you're playing at home. That's who they all were. And we show heart rate channels on the top, blood pressure in the middle, and the tilt angle. So when the tilt table went up, you can see, and when it came back down, you can see it. And if you look first at the healthy control subject, look at the heart rate, you will see that the heart rate goes up on tilt, right? Orthostatic tachycardia is not abnormal. It is physiology. It's supposed to go up. Second, if you look at the blood pressures, it's hard to look at those these are continuous blood pressure traces, but it's hard to look at the two blood pressure traces and argue the POTS patients have orthostatic hypotension or hypotension at all, right? I think if you look at the average pressures, the pressures are either the same, or if anything, there may be a slight trend to the blood pressure in the POTS patient being a bit higher. Now, you could look at this, the careful observer will look at this and say, but the POTS trace looks different, right? It looks a lot spikier. It looks like I do when I wake up in the morning in desperate need of a haircut, right? Hair's all over the place. And it turns out that actually may be important, right? So one of our postdocs or recent postdoc alumni actually is doing a lot of work trying to actually characterize these spikes. And it actually may be a response, the autonomic nervous system trying to maintain, upright posture, hemodynamics in a stressed state. So it may be important, but it's not hypotension, right? So no orthostatic hypotension. And then finally, if you look at the heart rate in the POTS patient in the top right, again, like the control subject, it goes up, but it goes up a lot more, right? These patients are overachievers. They can really get their heart rate up when they're upright. And just as an aside, this particular patient didn't survive or make it through, she survived, but didn't make it through the 30-minute tilt protocol. She made us stop early. And she made us stop. When she made us stop, her heart rate was almost 180 beats per minute. Okay? But as I said, POTS isn't just about heart rate. These patients feel miserable when they're upright. So, in this study, we were actually rating symptoms every 3 minutes during tilt. And you can see that the control subjects in black were pretty much asymptomatic. Every once in a while, someone would become a little bit symptomatic and then they'd faint and they'd drop out and the group would become asymptomatic again. But if you look at the POTS patients overall in red, they became symptomatic early, and they became more symptomatic as they went on. And there was a myriad of symptoms, but lightheadedness among them. The data I don't have here that one day I need to actually put into the slide is a higher percentage of POTS patients survived or made it through the 30-minute tilt than the healthy control subjects. Because the healthy control subjects, a bunch of them fainted on our protocol. The POTS patients, on the other hand, started telling me they were going to faint from the beginning, very early in the study. And they kept telling me for 30 minutes that they were about to faint, right? And that's an important point. And the point is that POTS isn't fundamentally a fainting disorder. POTS is a feeling faint disorder. They feel like they're going to faint. The rate of syncope, the rate of fainting is actually not that high. It's probably around 20%. Okay, so that's sort of the background for POTS. And I'm going to shift to, how does this actually impact the patients, right? And so up until the study I'm going to present, what we had were a lot of single center studies. We were responsible for a lot of them at Vanderbilt, where we focused on physiology or acute pharmacology, right? And by necessity, these studies are small. So we didn't have a good sense of how this is impacting the broader community. There was a sense, there is a sense that there's an overall poor quality of life. I mentioned that there was a prior comparison to patients with congestive heart failure, patients with COPD. There's another bit that I'm going to get to in a moment. There are problems with sleep, fatigue, and the symptoms can be debilitating. And again, of most interest to this group, at least 9 out of 10 patients, probably 9 and change out of 10 patients are female. Treatment for POTS, well, I'm always fascinated when asked to give a talk and told that the CME office wants me to declare if I'm going to discuss any off-label or non-approved medication. And the answer is, if I'm talking about POTS and the treatment, the answer is always yes, because there's nothing approved for POTS, right? So anything we do is off-label by definition. There was, during the CCS, or the Canadian Cardiovascular Society, position statement process, we had to actually grade the quality of evidence for different treatments. And as you can see, the overwhelming majority of data were deemed to be low quality evidence, right? Occasionally, we sort of got to a moderate if we were lucky, right? But there is a paucity of good evidence on how to manage these patients, and clearly a need for more studies in this space. So we also looked at quality of life. Again, this is data from Vanderbilt, and it was done in conjunction with Kanika Bagai, who's a sleep neurologist at Vanderbilt. And use the SF-36. Now, the SF-36 is a generic quality of life tool. It's nothing POTS-ish about it. So you may miss things, but the advantage of it is it's been studied in everything, right? So there's a lot of room for comparison. And the data shown here are not our data. This is stuff we ripped out of the literature of 2 disorders that are generally viewed as having a poor quality of life, rated with the SF-36. Patients with chronic back pain in green, and patients with end-stage renal disease on hemodialysis in purple, right? Where they have to come in 3 times a week and spend hours with their favorite nurses. These are our data for our POTS patients, right? So this doesn't speak to why. What this says is that POTS patients have a very poor perception of their quality of life. And before anyone sort of says, well, that's just their perception, all quality of life is perception, right? It's actually how, in every case, it's how you view, your existence, and specifically health related, right? So this just points out that there is a problem for us to deal with. It doesn't tell us how to deal with it. So what are the impacts of POTS? And really, where a lot of our data comes from is what we have colloquially called the Big POTS survey. This is a Vanderbilt University ethics approved study. So I started this shortly before I came here. In fact, it launched right around, I think, the same date I moved and started here back in 2014. And the official name is the Diagnosis of Impact of POTS. And this was importantly done in conjunction with a large POTS patient advocacy group called Dysautonomy International, right? So we were actually trying to address questions that patients had about their own disorder. Obviously, when I came here and wanted access to the data, we set up data sharing agreements. So now it's sort of a 3-way collaboration between these organizations. We started data collection, that was 2014, maybe it was July 2015. Data collection started a while ago. Until recently, it was still open for new participants to sign up. It's on hold because there's an issue right now at Vanderbilt with collecting data from international participants and whether we're going to go to prison because Venezuela doesn't want us to collect their patients, their citizens' data. But hopefully it'll open again. And this was basically a cross-sectional survey of the broad patient community. It was distributed basically through social media and online, right? It was all sort of an online survey through RedCap survey. We asked patients to respond only if they had a physician diagnosis of POTS, right? So not, I think I have POTS, but more, someone has told me I have POTS. And everything reported is from them. It's all self-reported, so none of it's verified, and that may be a limitation. And the first paper was published a few years ago, 2019. Brett Shaw is now an emergency physician here at the Rocky View, but he did this while in med school here. And Kate Bourne, who led most of the other things I'm going to be talking about, was also involved. And it just gave us some basic demographics. And this is what told us the POTS patients really do look like what we were seeing. Over 90% female, over 90% white. Now, exactly why that is not clear, right? So it's possible that this is actually a physiologic issue, but you know, while online surveys are a bit more democratic than do you have enough health insurance and money to travel across the US and come to see us at Vanderbilt or at Mayo, the survey was only in English, right? So that is a limitation that certain people may not have felt comfortable responding. But I will say that this is actually something seen in a lot of studies. And so there may be something that needs to be looked into. And if we look at the age of symptom onset, the most common age of onset was 14. Right? So females around the age of 14, that's the poster child for the onset of POTS. Now, importantly, though, it's not just a pediatric or an adolescent disorder. There's a long tail, and almost half the patients develop their symptoms, first onset of symptoms after the age of 18 in adulthood. And this may reflect part of the heterogeneity that I alluded to earlier, that there may be different causes in the different groups. So some around puberty, you know, maybe have something to do with puberty and hormones, but there's clearly something else going on if it's occurring in your late 20s or 30s. We had a laundry list of symptoms that we asked people to endorse or not. And these are the things that came out on top, most commonly reported. Lightheadedness, the things you'd expect with a tachycardia-related disorder, lightheadedness, tachycardia, presumably palpitations, pre-syncope were at the top. But the next few, again, not something I'd necessarily expect from a tachycardia disorder. Headache, 90%. Difficulty concentrating, 90%. Nausea, just under. Memory problems, high 80s, right? So again, not just a cardiovascular presentation, major symptoms that are non-cardiovascular in nature. You know, one of the things when you have a disorder that affects 14 and 15-year-olds is to ask, what are 14, 15-year-olds supposed to be doing? And for the most part, it's going to school. And that's a problem, right? So almost 90% of participants, presumably that had POTS at that age, reported missing school. Almost 30% were homeschooled. Now, I think we made the assumption that this was for health reasons and not religious reasons, but you know, having lived in Nashville for years, that was probably an omission not to ask that specifically, the why, right? But presumably for health reasons, for sure it happens. 25 patients had to drop out. And then when we get to higher education, almost 40% had to delay or postpone some of their higher education, delay university, postpone enrollment, take a gap of a few years to get their health sorted out. So this is a critical issue, right? Because it turns out those years, it's not just a matter of I've lost 2 years or 3 years of my life, you know, while trying to get this treated. These years actually determine the trajectory for the next 20 or 30 or 40 years of your life. Like how you train and the path you start on will largely determine, you know, where you end up, right? So this is actually a big problem that needs to be addressed. So in this first paper, there were just under 5,000 participants. Just as an aside, you know, we only asked people to fill out the survey if they had a physician diagnosis of POTS, but just in case, we asked the question again. And about 10% actually didn't tick off that they had a physician diagnosis of POTS. So we excluded them from these analyses. So they could be lying to us, but they would have had to lie twice, not just once, to be included. The demographics are shown here. Most of the survey, the overwhelming majority, was American, was US based, not all. There were issues that we came up with on diagnostic delays, and I'll touch on that a little bit. And most of the diagnoses, rightly or wrongly, were made by cardiologists or cardiac electrophysiologists. Really for no good reason, I suspect, except that tachycardia is one of the key presenting features. I'm not sure that cardiologists have any other better insights into managing the overall issue. There are other analyses that we've looked at. Obviously, if you have a disorder that's affecting education, affecting, potentially the ability to earn money, make you sick, this has economic impacts, both direct and indirect. And we've tried to look at that. We've looked at sex differences, and we've looked at pregnancy. And so I'll share some of these data with you. So our economic analysis was published a few years ago. This was led by Kate. This had about 5,500 participants in this cut of the paper. Kate was nice enough to put in QR codes. If you're interested, you can sort of, play along and look through the paper and make sure I'm not misrepresenting as I go. So in terms of employment, a little under half the group was actually employed in the 3 months prior to the survey. Or put another way, over half the group wasn't employed. 2/3 actually reported they would work more. And employed doesn't mean fully employed. Employed means employed at all, right? So a lot of employed is part-time. 2/3 of the overall group said they would work more if not for their POTS and related symptoms. Over 80% called in sick. I assume it's more than once ever, called in sick with some frequency. So overall, a high burden, both of illness in terms of, losing hours, but also for employers, right? And that actually becomes a problem in terms of keeping these patients employed, even for, the employers that are fairly easygoing. And sometimes the gaps where they're not able to work isn't just a matter of missing a day or two, right? But they actually miss chunks of time where they go into a cycle where they're unwell for more prolonged periods of time. And we used greater than a week as the definition of that. Over 20% have lost their job because of their POTS, right? Again, understandable if they continually aren't able to show up for work. And almost 3/4 have had to modify their job because of their POTS. And some of that is shown here. In terms of lost income, 70%, over 70% have lost income in the 12 months prior to when they completed the survey. Again, that was a bit of a moving target in terms of when they did it. And it's a little difficult to fully quantify this. We created little bands for them to estimate how much income was lost. We put it in US dollars because most of the participants were American, right? But not trivial amounts of money. We're not talking about just a few $100 for a lot of people. It's some cases 5 digits, tens of thousands. We're going to do a fairly quick tour. What about sex differences, right? I mean, this is a disorder overwhelmingly affecting females. Does that affect, I guess, improvement in diagnostic yield in the female patients or not? And so this was published a couple of years ago. Again, a lot of this came out just early COVID. We had a larger cohort here, so almost 9,000 participants were included in this analysis. Close to 95% female. The interesting thing is, even in a female predominant disorder, an overwhelmingly female predominant disorder, the diagnostic delay was significantly longer in the females than in the males. Now, I do want to point out, as the minority here, being male, I mean, that the diagnostic delay was pretty shitty for the men as well, or for the males as well. I guess we were asking about gender, but for the males as well, right? But it was even worse for the females overall. And the reasons for that, I guess, aren't clear. It just is. The rate of misdiagnoses was similar. And both groups had to see a lot of doctors. an average of 7 doctors before they got diagnosed with POTS, right? So 7 doctors for the symptoms that ultimately were deemed to be POTS. We asked about issues around, referral to psychiatry, both before and after diagnosis, and ultimately, and related things, and females were slightly more likely to be told that this was, I'm not sure if we actually used the phrase in the head or if it was psychiatric. We may have actually asked about in the head. That may have been an exact phrase. And in many cases told that they just needed to exercise more, right? It was a deconditioning issue alone. When looking at quality of life, overall, I think you can sum it up by saying pretty shitty for both groups, right? I don't want to make it sound like the males with POTS have a great quality of life and the females don't, right? The truth is the quality of life in this disorder overall is poor. There are some interesting little, blips, and I'm not sure fully what to make of it, but using the RAND36, by the way, is an early version of the SF36 and is open source, so free. So this is actually what we use in a lot of our studies. But the 8 domains are similar to the SF36 and are portable. But when you look at this, there's a slightly worse physical functioning, or PF, in the females, slightly less general health described in the females. But their emotional health is actually a little better than the males, right? Which, again, I don't have a good explanation for this, but when thinking through, issues around gender, for example, a lot of what I'm told to be thinking about is issues around roles and, perceived what you're supposed to do or what you need to do. And this may play a role, but it's just interesting that despite, the physical stuff being a bit described as a bit worse, the emotional health was either better in the females or more likely probably just worse in the males for whatever reason. And this is using summary scores of physical health subscores, mental health subscores, and general health. And again, we see this where the mental health is a little worse in the males, while the physical health is a little worse in the females. What about pregnancy? Obviously, this is an issue in a female-dominant disorder, and a female-dominant disorder that we often describe as women of childbearing age, younger female disorder. Pregnancy is obviously an issue of significant interest. And so we looked at a group. There were less people that had been pregnant. We, obviously we're excluding the people that were too young or chosen not to. So we had a little over 3,500 participants who reported that they had 1 or more pregnancies. And we wanted to sort of try and figure out what the impact of the pregnancy was on their POTS symptoms. And so we broke this down by trimester. And basically, most of the patients said that their symptoms were worse in the first trimester than before they got pregnant. Right? And that actually sort of, I think I would have expected, right? First trimester, often there's a lot of nausea, vomiting, hydration may be difficult, keeping up with fluid loads that we often request in terms of treatment for the POTS patients would be difficult. The hope was that by the second trimester, when the physiology changes and blood volume increases in pregnancy, that the symptoms, that they'd actually be better. In fact, going into this paper, there was a traditional thought that 2/3 got better and 1/3 got worse in pregnancy. That's not what we found. Half still got worse. And then the third trimester was worse yet. I'm not sure what to make of that. I haven't met too many women that enjoyed their 9th month of pregnancy, right? I'm not sure how much of that is unique to POTS versus, everything just gets full and uncomfortable, and that's sort of the way it is. But overall, symptoms worse during pregnancy. And it turns out you can, if you accept that overall it's worse, you can sort of pick out people that may respond. So if you actually did better in the first trimester, if your symptoms improved in the first trimester, that actually boded well for how you would do later in pregnancy. The problem is that was a minority, right? So most didn't, but if you were in that select group, most of those people, not all, did continue to do better. Right? If there's no change, or if you got worse in the first trimester, you're pretty much hooped, right? The rest of the pregnancy was not going to be fun. I think the final bit-ish is long-term outcomes. And these data are actually in review and not yet published. But one of the questions that people often ask, they're often young women, and they want to know what's going to happen down the road, right? Not just in the next few months or a year, but further down the road, right? I think they plan to be old women at some point, and they want to know what that's going to look like. Is this going to go away? And so one of the challenges is it's a relatively young disorder, right? In terms of people diagnosed with POTS, it's only been around for 30 years, right? The criteria were 1993. But at Vanderbilt, they've been doing work certainly since the late 90s on this. And so, in conjunction with Vanderbilt, we actually went back to patients that had been seen on the Vanderbilt Research Unit at least 10 years before we sent out the survey. So basically late 90s to about 2010, 2011. And so we created a survey. We created questions that were specific to POTS in terms of the journey and better, worse. We also used some sort of structured and validated metrics of symptoms. The Compass 31, that's a fairly ubiquitously used autonomic symptom score, not POTS specific. It's actually more for autonomic failure, but widely used. The RAND 36, which I've mentioned, and the VOS, the Vanderbilt Orthostatic Symptom Score. When I described the symptoms early on with TILT, that was actually the genesis of what has turned into the VOS, so a more structured and now fairly widely used symptom score. And ultimately, we had 45 patients respond to the survey and give us data. The median age at response was 48, right? So older than what we typically see because we saw them a while ago. And the average time from onset, 10 was the minimum. The average time from symptom onset was 23 years. The average time from POTS diagnosis was 17 years. Remember, there was a delay. This delay is longer than what I reported in the POTS survey. And what I probably should have said is we did look at the effects over time. And more recently, the diagnostic delay is shortening compared to people from 20 years ago. So that's the good news. It's still really long, but it's getting better, right? But these people were diagnosed on the earlier part of the window. And the short answer to will my POTS go away is not likely, right? So one person out of the 45 thought that, now it's, the fully resolved is hard to see. If you sort of look up here, there's that little sliver on the far right at the very top that's hard to see in light blue, teal, something like that. One person. So the overwhelming majority continue to have symptoms. Now, that doesn't mean everyone had the same burden of symptoms. A bunch of patients improved, some got worse. I'm not sure if we're showing you other analyses. We've tried to break it down by those that got versus improved versus got worse and looked at stuff. We had to exclude those with variable presentations. But the point is, overall in the group, things can vary over time, but it doesn't just totally disappear for most folks. So we then tried to sort of break it down by looking at what are the factors that predicted those that improved and those that didn't. And those that said that over this long duration, they fundamentally weren't improved, actually reported having symptoms that we could attribute to neuropathy-related symptoms, so tingling, paresthesia, things like that, overactive bladder symptoms, or gastroparesis-related symptoms. So when they eat, they get early satiety, they bloat, they get nausea when eating, they can't keep food down, right? All things that could be consistent with other forms of neuropathy as the underlying presentation in those patients. And that's shown here, right? Huge difference in those specific things. The other stuff was pretty much a wash. So I will stop by saying that POTS patients have a lot of negative impacts on a lot of things. There's significant economic loss impacts from it, largely related to employment. Despite being a female dominant disorder, still takes more time and is harder for patients to get diagnosed than male patients. And for the most part, not in everyone, but in the vast majority, symptoms get worse during pregnancy. But the flip side is they can get pregnant, they can carry pregnancy, babies through to term, and there's no signal that the babies are harmed anyway unless they take one of the few drugs you really aren't supposed to take in pregnancy, right? So it can be done, but you may feel miserable doing it. And then in terms of long-term follow-up, most patients continue to have POTS-related symptoms decade after symptom onset. And in fact, may be able to predict people that do particularly poorly based on some presenting symptoms. So with that, I'll stop and happy to answer any questions.